So look, my name is Paula Leonard. I am the CEO of Alcohol Forum Ireland. For the past 7 years, I've had the absolute pleasure and honour of working with regional and local drug and alcohol task forces, 14 of them through the Irish Community Action on Alcohol Network that was formed in 2017 based on an acknowledgement that while the causes of alcohol harm are felt, the effects of alcohol harm are felt very much at a community level, that people are living with alcohol harm, they're living with alcohol-related violence, they're living with, alcohol-related litter in their playgrounds, very simple things to very big things. They're struggling children in homes, that all of those harms are being felt at the community level, but what is driving those harms has to be addressed at a wider policy level. And so the Irish Community Action and Alcohol Network was born out of that sort of acknowledgement that we needed to join the dots and work together collectively. And since that time, really, communities have begun to find a voice in policy making in Ireland, something that they had really struggled to do. And I'm absolutely delighted that last year, when the European Framework on Alcohol Prevention was launched, that communities and community mobilisation was included in that as one of 6 themes. So there's absolutely a growing recognition that what we need is research to work with us at the community level. We also need it at the population level, but it needs to be from the bottom up and from the top down, and we need people to work in partnership with us. Sometimes that's been absolutely fabulous. Sometimes that's been a real struggle to find partners who believed in us and believed in the work. So this afternoon's session is called Carrying Out Your Own Alcohol-Related Research and Perspectives from the Community. I also just want to acknowledge that one of our own community action and alcohol activists is actually talking today in Barcelona at a WHO event on this theme exactly. So this theme is becoming more and more important. And Marie Lawless, as the alcohol and the policy lead in Ballymun Drug and Alcohol Task Force, is going to be able to talk about 3 waves of research that they've done in Ballymun over the last decade. And she's going to be able to talk about how that research has mattered to them as a community and how it has driven change at the local level and the changes that they've been able to make at an interagency level, working together in services, working on the environmental piece. And we're also thrilled that she's a PhD candidate. So we've been connecting these themes over the last number of years, and we do feel that we're beginning to have a voice, and have a voice here today is great as well. So it is my pleasure to introduce Anne Doyle. Anne Doyle is a research officer in the Health Research Board. Her work involves collating information about alcohol use and related harms in Ireland. She is passionate, and I can verify that, about promoting the use of this evidence to influence policy and practice to help reduce the harms associated with alcohol use. She has co-authored the 2 most recent HRB overviews, Alcohol Consumption, Alcohol-Related Harm, and Alcohol Policy in Ireland, and Alcohol and Other Drug Use Among Children and Young People in Ireland. And I suppose we have been just blessed to have Anne move into the area of alcohol research in Ireland, and she described it recently as, I've been bitten by the bug. So the bug, would please come to the stage and do your presentation. Thank you, Anne.
Thanks, Paula, and thank you everyone for staying along for the afternoon session. So I'm just going to give a brief overview of how we put together those alcohol overviews and what data is used. And I'm going to have slides that kind of give the pros and cons of those data sources, which do identify the gaps and where we could do better, so what recommendations we make. I think it's important for all of us to use a slide like this when we're doing presentations, no conflict of interest to declare. So firstly, the HRB alcohol overviews. We have done 5 to date. They are a collation of information about alcohol-related harm and how much we drink in Ireland, and our patterns of drinking. And they are used to inform the Department of Health so that when they're making decisions about legislation, that they have the evidence to hand. So the sources of data that go into those overviews are, firstly, we look at per capita alcohol use. I know someone spoke about this earlier, and there's a little bit of rehashing of slides here, but when we look at per capita alcohol use, this comes from revenue, and revenue give us a breakdown of how much alcohol is sold in Ireland every year. And this is an infographic here taken from the last overview. And this source of data is, well, it's the gold standard. It is what other countries use to determine their alcohol use. It gives a quarterly breakdown. It's broken down by alcohol type, so we know that how much beer, wine, spirits, and cider is sold. And then we have a figure of the net duty that's paid. But the downside of the revenue data is that there's nothing else. We don't know anything else about who is buying the alcohol, their age. We don't know if it's on or off trade. We don't know geographically where it is. We know nothing else. It doesn't include alcohol purchased abroad or cross-border, which is important to us, obviously. And we spoke earlier there about alcohol in airports. That's not captured either. And I think we know that there's a lot of alcohol consumed in airports. It also doesn't include home-brewed or products not for human use, so such as hand sanitizer. And actually, a recent study has shown that about 10%, nearly 12% of our alcohol consumed in Ireland is in this bracket, so that's not considered in it. But it's the best we have. So to look at our patterns of drinking, we use these two surveys primarily. There's a lot of different ones, but these would be the two main surveys. The National Drug and Alcohol Survey and the Healthy Ireland Survey. So both of those have taken place. There's been a few different waves of them, and with the Drug and Alcohol Survey, it includes tobacco and gambling as well. And the Healthy Ireland has a whole suite of different questions about your health. So different variables can be used to look at alcohol use. This is just an infographic. I think Zubair had one similar about the patterns of alcohol use in our country. We know that we are a nation of hazardous drinkers and that we have a high level of alcohol use disorder. But with these sources of the Healthy Ireland and the National Drug and Alcohol Survey, the pros are that they're regular, they can be used to track trends. Healthy Ireland is every year. The National Drug and Alcohol Survey has been about every 4 years. Sorry, am I moving on there? Oh, no, sorry. They are nationally representative. The samples that are used for both of those use a sample that represents the Irish population. And what's reassuring is that the findings are consistent in both, so we know that they are valid findings. And they both use international classifications for measuring hazardous alcohol use and alcohol dependency, which means that we can compare our information to other countries. On the other hand, we know, and this isn't just an Irish problem, but internationally, surveys looking at alcohol use are an underestimation of what people drink. For example, in the 2013 HRB diary study, this was again, it was a representative sample, but what people reported drinking was actually only, I think it was less than 40% of what was sold in the country. So we're not honest, or we don't know how much we drink. So our surveys cannot be relied on for how much we drink. Similarly, there's a lack of awareness of drinking patterns. Deirdre did a paper recently looking at responses to how you would classify your own drinking, and the majority of drinkers said they were light drinkers, where in fact they were moderate to heavy drinkers, and even among alcohol-dependent drinkers, they class themselves as light drinkers. So there's very much a lack of awareness. And with surveys, and again, not just an Irish problem, but there are groups that are not represented. We know, for example, that in the National Drug and Alcohol Survey, that those who live in residential settings or in prisons are not represented. There is a low uptake of young males from lower socioeconomic groups, so it's very difficult to get those to participate in surveys, so they're not represented. People who are in direct provision and pregnant women, there's lots of different kind of subgroups that we're just not covering in our population surveys. So I've just included a slide on our sources of data for young people because of the overview that we did there recently on alcohol and drug use among young people. And we have down the left-hand side there, we have a lot of surveys, really, really valuable ones. The Growing Up in Ireland, the HBSC, SPAD, Planet Youth and My World. And they collect a whole suite of information about not just alcohol and drugs, but young people's lives, and it gives us an insight into what's happening in young people's lives, and especially in relation then to alcohol. On the downside is, and I actually struggled to come up with too many cons, but I suppose I think it was Paul who said earlier about PPI, and I think staying up to date is important, and I'm not 15 or know nothing about what 15-year-olds are doing. So I think it might be important to involve young people in our surveys more so than we are to stay up to date, because it's changing at a rate that we as researchers can't keep up with. I have that most of these surveys don't capture adverse childhood experiences, which we know have an influence on alcohol use in later life. But I say that, and we actually are working on a project looking at Growing Up in Ireland data with Margaret and Noel to look at the influence of ACEs and your drinking and drug behaviour in later life. So that'll be interesting. And like our population studies, there are groups that are not represented. So moving on to alcohol-related harms, this is a slide looking at hospitalizations, alcohol-related hospitalizations. It gives you a snapshot to show that, I think this is 2020, there was over 40,000 alcohol-related hospital discharges, about 3,500 alcohol liver disease discharges, and the length of time that alcohol-related conditions take to be discharged or the length of stay is about 10 days, so quite a long period in hospital. This information comes from HYPE. I'm not sure if you're aware of that one. It's the Hospital Inpatient Inquiry Scheme. And it is a fantastic resource in that you can look at the main diagnosis that someone has been admitted to hospital for and up to 29 other diagnoses. So it gives you a nice, it's not just limited to the one. It includes day patients and inpatients, the number of bed days per patient. It includes people who've died in hospital. It is limited to public hospitals, but if you're a private patient in a public hospital, they are captured in it. Again, it uses an international classification, the ICD-10, and includes costs of hospital stays as well, so that's a useful resource. A huge negative of HYPE is that it doesn't include the emergency department presentations. I know they're trialling in Tullamore, I think it is, they're trialling HYPE in emergency departments, but it's at a very early stage, and I'm not sure how useful it's going to be because I'm not sure if they're going to include as many diagnoses as we'd like. So I don't know if we'll get much from that in terms of alcohol-related emergency department presentations. Another negative of it is that it's cases only. So if a person attends hospital a couple of times over the year, they are counted twice rather than per person. So that's a bit of a downfall. It doesn't include small areas, so we're not able to get kind of geographically where the patients are coming from and what sort of background they're coming from. So I can't do any analysis, we'll say, on deprivation. And as I mentioned earlier, it doesn't include private hospitals, which is a big gap considering I think we'd probably have pretty high private health insurance in this country. Alcohol-related deaths comes from the HRB, the Health Research Board's National Drug-Related Deaths Index. It gives an estimate of, actually it doesn't estimate, it gives the rate of deaths per day at three alcohol-related deaths per day, which is slightly different, was a lot different to what Zubair mentioned earlier from the global burden of disease, but this is because it is very specifically wholly alcohol attributable deaths, whereas the global burden of disease takes into consideration partially attributable alcohol deaths. What the NDRDI has shown us is that 2 in every 3 of those deaths are of people of working age, which highlights the impact that it's having on our young working people. The NDRDI is an amazing data source because it collects and cross-checks all the data from from different sources. So we can look at trends over time then, because it's been in existence for quite a few years now. And the coronial data has been used extensively for other projects. For example, we've looked at fire deaths, road traffic collisions, suicides, homeless. There's a whole suite of reports that have been done using the NDRDI data. The cons are that it is not up to date. It's a very laborious process of trying to collect the data, because we have a team of research nurses who go into the coroner's offices and they manually go through every single file of every death that's reported to the coroner, which is about 20,000 every year. And there's a small team of research nurses who literally go through page by page to see if the death is alcohol or drug related. So it means that there's a delay on getting that data. There's also been a delay because of COVID, because the nurses couldn't go in to the coroner's offices. There's no standardization of practices, so what one coroner could record in one part of the country can be very different in the other side of the country. So it's not standardized process. It's not collected for research purposes, which can be very frustrating for us. So there isn't, what we're looking for isn't always clear in those reports. And there's no national database. This is a huge hole that the nurses are going in to collect this data and look at this data. If there was a standardized national system, it would save a lot of heartache. In terms then of alcohol treatment, there's about 7,500 cases of treatment for problem alcohol use, and that is only those who were treated for alcohol as their main problem substance. In fact, it's a lot higher when you count in the number of people who receive treatment for another drug, but alcohol might have been a secondary problem substance. That information comes from the NDTRS, which is the National Drug Treatment Reporting System, and it's really useful resource in that they capture polydrug use. So we know if alcohol, as I say, is the first or a second substance that was requiring treatment for. It looks at first or repeat attendances. It includes the type of service provider and includes private services. There's a whole suite of socio-demographic details that can be examined, and it's been in place for quite a while, so we can look at trends as well. The downside is that it's an underestimation. It only covers 70% of who it should cover. So we know that there's a bit of a gap there in terms of, I think it's GPs treatment are not providing some of the data. So that is one of the negatives of it. And like HYPE, it is cases only. So if a person receives treatment multiple times during a year, they're counted each time rather than per person. Very quickly, looking at NPERS, the National Psychiatric Inpatient Reporting System, it looks at psychiatric admissions and discharges. It's been going for a long, long time. We can look at trends. A huge gap is that it is only psychiatric hospitals and units, so it's not community services, so we don't know. That's a huge cohort of people who are receiving psychiatric treatment for alcohol. Again, it's cases only, and it doesn't reflect incidences of alcohol-related mental illness. I'm going to fly through here just to highlight the prevalence and the intertwining of alcohol and mental health. We use the National Self-Harm Registry and the Suicide Support and Information System to look at self-harm and suicide and the involvement of alcohol. These are just some of the sources of data on mental health and the relationship with alcohol. So you can see that there's quite a list there, including the treatment and the deaths database, who have more recently included a couple of questions about mental health prevalence as well, which will be very useful going forward. And I've just the cons, I mean, it's difficult to diagnose sometimes. Historically, I suppose, alcohol and mental health have been treated separately, so sometimes it's difficult to know which came first, chicken and egg scenario. So it can be difficult to capture in surveys, and that's where the suicide and self-harm data is very useful. The social consequences, this is looking at pulse data, and there's a very useful couple of reports from the probation services and population surveys, say with the drug and alcohol survey, and SPAD, for example, ask about alcohol-related harm. There's a huge gap in pulse. I think we're all fairly familiar in that it is released by the CSO, but with many kind of disclaimers to excuse the data, but it's as good as we have. The location of the crime isn't recorded. Again, it's not for research purposes. And the probation services report, as useful as that is it's an ad hoc publication, so we can't rely on it. In terms of alcohol availability, this comes from revenue, where they provide a list of who is issued a liquor license, and that was a map there just showing where they are, which is everywhere. And revenue provide quarterly updates. They break it down by license type and county, and we can track trends over time. The location of the license is so vague, it gives you very little away, but we have managed to match them all. Paula will be pleased to know. It includes premises that might have been closed because people will renew a license, but actually the premises might be closed. But we don't know anything about the size of the premises or opening hours. There's a lot of gaps there as well. So I am out of time. Will I just do a very quick... as I pointed out there, the challenges are that there are hard to reach groups in our prevalence surveys. There are gaps. The huge one is the emergency department, but hopefully Tobias's work is going to shine a bit of a light on that. Ambulance call-outs is a huge one that we don't know nothing about, and I was told by the ambulance services it was like looking for a needle in a haystack to get that information. Polydrug use is still a bit of an issue in that we're not fully we're still working in silos in terms of other drugs and alcohol, and really they should be, they're both being used at the same time. And Frank spoke earlier about FASD and alcohol during pregnancy. Private data sources, I think Kantar and Nielsen, these are where you can buy data about alcohol use, and they would be, I think they would be amazing sources of data which would tell you an awful lot about drinking patterns, but they're too dear. And then small area data, it's always very useful if we can pinpoint where people live in terms of alcohol use and alcohol-related harms, but that is not in many of the data sources. So a recommendation is cross-systems collaboration. So, for example, my colleagues worked with Pubble, and they looked at deprivation and treatment. So it was highlights how, we can work together, and if you use two different systems, you can really create something amazing. Use the data is just an encouragement to look. All of those sources have amazing amounts of data. One question in a whole questionnaire is a whole PhD thesis. Use it. We need timely data. Be involved in conversations. Department of Justice and the Department of Health talking together so that we don't have two conflicting pieces of legislation. And how important it is to monitor the Public Health Alcohol Act. We have, it's an amazing piece of legislation, but if we're not monitoring it, it's not worth its salt. So thank you so much, and thank you all for coming along today.
Thank you very much, Anne. I was at a conference yesterday in Derry, and I suppose it's just in relation to data, it did strike me that they were able to say that per 100,000 of the population, that people in Derry are 5 times more likely, and people in Strabane were 5 times more likely to die as a direct result of alcohol. So it's really important that we move to that sort of level of being able to address things in a meaningful way, because we need whole population measures, but we also need to be able to target disadvantage. So thanks a million, Anne. I found that really interesting and useful, actually. It maps out some of the road we need to travel. Now, the next person on the agenda is probably the only person on today's agenda that I didn't know. So I'm going to read this one. Dr. Catherine Gill has managed diverse award portfolios in the Research Strategy and Funding Directorate since joining the Health Research Board. She's currently the Programme Manager for Targeted Programmes, whose suite of activities and awards is guided by research needs and priorities of the Irish health and social care system. She is HRB lead on the recently awarded Transforming Health and Social Care Systems partnership under the Horizon Europe, and she represents the HRB on the Joint Programming Initiative on Antimicrobial Resistance. In addition, she has responsibility for grant policies related to research integrity, and she represents HRB on the National Research Integrity Forum and the European Network of Research Integrity Offices. So with a background in cell biology, prior to joining the HRB, Catherine spent 8 years as a researcher, most recently in UCD. She has a BSc in biotechnology and a PhD in molecular biology from the National University of Ireland, Galway. Having read that, I'm not quite sure how she has time to be with us today, but I would like to welcome her to the stage and just ask you all to listen again. Thank you.
Thanks, Paula, and thank you, everyone. Leading on from Anne's talk and the urge to use the data and to do more research, I'm just going to talk to you about some of the funding opportunities that the HRB have to provide the money for that research. So you're, at this point in the day, I think, very familiar with the Health Research Board. So it's just to reiterate our vision to advance health research through excellent research data and evidence. You've heard from my colleagues in the National Health Information Systems and Drugs Library earlier. I'm going to focus in on the research funding arm of HRB. And before I get into the details of what we fund, just to point out that where we fit in the national funding context. So we sit alongside a lot of other agencies that fund elements of health research. For example, Science Foundation Ireland fund a lot of biomedical research. The agencies under DAFM would fund health research as it relates to, for example, food or environment. But as the main agency of the Department of Health, we would fund the most research in terms of health and social care research, and within that, public health research. What we fund can be broadly categorised into 4 areas: capacity building and leadership enhancement. So that's funding individuals through fellowships and leadership awards. We fund infrastructures and networks, interventions in the form of clinical trials, and also projects and programs. And as you can see, projects are by far and away the largest number of awards that we make. If you look at it a different way in terms of the distribution of funding, you can see in this period from 2020 to 2022, a lot of our funding went towards infrastructures and networks. But that was largely because that was a very busy period in that category, with a lot of funding for clinical research facilities, clinical trial support, and that type of thing, which can be quite expensive. If we break it down by the broad research areas, we fund very little in the way of basic biomedical research these days. We would have way back in the past. And anything we do fund is really through collaborations with other funders. So our focus is on clinical research, health services research, population health sciences, and applied biomedical research. And again, depending on the time period you look at that, it'll vary a little bit, but typically mainly clinical and health services research, and a good amount then of pop health and applied biomedical. So I'm just going to give you some examples of the schemes, the funding schemes we have, and first starting with projects. And after Anne's talk, I think this is probably a good start in terms of the secondary data analysis projects. And the aim of this scheme is to make sure that people are using the data that is there to fund research that is answering priority questions in the Irish health and social care system. So the databases that Anne talked about are a really good example of the type of thing we want to encourage further use of. And if you wanted to use those databases, the secondary data analysis scheme is a good place to start to look for funding. And an example here of a recent award is for prescription drug use, misuse. And the researcher here used several different databases in the same way that Anne has to triangulate data and to answer these research questions. The Applied Partnership Award Scheme is very much about the partnerships. So that's a partnership between an academic researcher and a knowledge user. And by knowledge user, we mean someone who will actually use the outputs of the research. So, for example, it might be somebody in the HSE or the Department of Health or in a clinical setting. And the idea is that by being involved from the start, from developing the research question right through the end to dissemination and implementation, it's more likely that these questions will be relevant in the first place and then that they'll actually use the data at the end. So the example here around Ireland's Physical Activity Research Collaboration, which is supporting implementation of the National Physical Activity Plan. This is a collaboration or partnership between researchers in UL and the Healthy Ireland team in the Department of Health. The investigator-led projects, then, the third example here, is a little different. It's a bit more open. It's not solely about Irish priorities. It's looking more at global health challenges. Investigator-led projects at a highly competitive international level, so that they're adding to the international knowledge base. But of course, this is also going to be very relevant to the Irish system. And the example I have here is a population health project looking at mental health and well-being during the transition from childhood to young adulthood. So just to compare some of those, because there's a lot of similarities, but there are differences, and I suppose the big one for STAP or secondary data analysis is that requirement for an existing data set. That's the whole purpose of that program. In the case of applied partnership awards, the focus is around, as I say, that partnership with the knowledge user, and that has to be backed up by co-funding from the knowledge user organisation. Neither of those are requirements for our other schemes. This is very specific to APA. In terms of the duration, the STAP and the APA are really about applied research and hope that what they're working on will be relevant to the system very quickly. So the shorter in duration, whereas the ILPs, which are kind of adding to the knowledge base more so, again, they might be relevant soon, but that's not the main focus. So they're longer, up to 4 years. And that's reflected in the funding, the shorter applied awards, up to 250,000, and then a bit more money for the ILP. I'm not going to get caught up in this cycle terminology, but just to say that frequency-wise, the applied awards come up about every year, an opportunity to apply. And the idea there is that they're a bit more responsive to emerging needs in the system, whereas the ILP, probably every 2 years, there's an opportunity to apply. Some important dates there. The STAP current round is closing on the 4th of October and the ILP on the 11th of October. If you haven't thought about them already, it's a tight time to actually make an application, but anything is possible. And if not, there is another APA call coming up next year. So moving on to funding to support people, we have awards at all stages of the career pathway. Starting with PhDs, and we fund most of the PhDs we support are through the structured training programs. So we have Sphere, which is focused on population health policy and health services research, and then the corresponding program for a clinician scientist is ICAT, and that is open to all medical disciplines. We also support postdoctoral fellows, but I'm going to skip on to level 3 here, to this mid-career level and emerging investigators, because there's 2 calls open at the moment. The EIA, or Emerging Investigator Awards, is focused on the academic researchers, and then there is a parallel ECSA for the clinician scientists again. And again, just some examples of the types of awards we funded through these initiatives. The first example there, looking at the use of evidence in public health decision making. There's another on problematic polypharmacy in community dwelling people. There's one on the influence of corporate food industry on public health policy, and the last one there on providing improved care for self-harm. And just to summarise again, as I say, there's schemes for all career stages. I've spoken about the doctoral and the emerging investigators, but at postdoctoral level, we have a fellowship called the Applying Research into Policy and Practice. That's just closed for this year. The round is almost complete. So the next call won't be for another year or so. And similarly, the leaders, the Research Leaders Awards, which is kind of the top of our career ladder in HRB, there should be a call in Q3 of next year. But Annalisa Montesanti, pictured there, is our careers guru, so if there's anything you want to know about these careers pathways, she's the person to contact. I'm going to segue now into European funding opportunities. There's a lot more that we fund directly, but just to touch on this, we provide advice and support for researchers who want to apply to Horizon Europe. And if any of you have looked into that, it is quite a complex system. So any help is probably welcome. But one of my colleagues has prepared this guide you see on screen there, and you can have a look at that on our website, which just takes you through the different steps you need to do if you're interested in finding out about the opportunities. So I would recommend to read that first, and then maybe get in contact with Irene if you want to know a little bit more about what opportunities might be available for you. In parallel to that, there's the EU for Health programme, and that is more in the area of public health, supporting actions in disease prevention and promotion, health promotion, amongst many other areas. Again, the national contact point for that programme sits in the HRB, and that's Amanda Daly, and she recently prepared she held an information session, which you can watch back on our website there. So these are where we provide support for people to apply themselves to these EU programmes. In terms of direct funding, we also are involved in joint transnational calls, and that's where we collaborate with partners all over Europe to co-fund projects. So, for example, if a team is successful with Irish and other researchers, we fund the Irish researchers. The new instrument for this is partnerships, and I just wanted to highlight these two partnerships that HRB are involved in. They kicked off in 2023, so there's the Transforming Health and Care Systems, which is like Sláinte Care at a European level, and then there's the ERA for Health Partnership, which is more in the public health space. And both of these will have calls every year for 7 years. So there should be lots of opportunities there for this audience. And just to say that the themes or topics tend to be quite broad, so there's usually a way to pitch your research that it will actually be a good fit. And just some examples, there's been no awards yet in these two partnerships because they're new, but some previous examples have been around antimicrobial resistance, around a policy evaluation network, and the first 1,000 days strategies to prevent childhood obesity. So these were all done in collaborative cross-European partnerships. So I've just scratched the surface of all of this, so just to summarize some of those opportunities. I've mentioned the projects and the career supports. We also have a number of program grant opportunities. That's where you have a suite of projects around a thematic area. We have a specific stream for interventions, so definitive interventions and feasibility studies. We support infrastructures like the clinical research facilities and clinical trials infrastructures, and a number of different networks. So they might be around a research area such as dementia or a particular group of clinical trial studies. But we also have networks, for example, on methodology support, on evidence synthesis, and on supporting development of PPI or public patient involvement. And then I mentioned our co-funding with European partners, but we also fund with others. And nationally, for example, we have a collaboration with the Health Research Charities of Ireland to fund a project grant scheme. And internationally, we also co-fund with the NIH and along with our colleagues in SFI in the US Ireland programme. Just if you want to find out more about any of these, on our website there's lots of information, and if you click into any of these you'll find lots of guidance, and if you want to quickly to the chase, there's contact points there if you want to pick up the phone and talk to anybody about it. And briefly to mention our other supports, so we fund the PPI Ignite network, and that's to help people build capacity in PPI capability amongst the research groups. Evidence Synthesis Ireland provides training in evidence synthesis, and then on the right there we have the TMRN and the NCTO, both of which are initiatives which support clinical trials and interventions. I mentioned our collaboration with HRCI for that project grant scheme that focuses on the priorities of the individual charities, and that's where it differs from our own project grant schemes. And then the last one there is HRB Open Research, which is our open publishing platform, which is always worth a look because there's a lot of great Irish research on there, and if you're funded through HRB, you can publish there. Just to finish off, a reminder of the various calls and opportunities coming up. We have those projects grants closing in October of this year. We have some careers schemes closing in November, but there's always more opportunities coming on stream, and plenty more in store for 2024 and beyond. So lots of contact points there, and also please feel free to contact me if you have any questions on foot of that. Thank you.